Happy Monday morning, everyone. Hopefully everyone had a nice breakfast. Thanks for joining us today. Super excited to see everyone at Age+Action. We're really excited for the next couple of days. My name's Russell Slater, Director of Corporate Partnerships at the National Council on Aging. Really excited to be here today and introduce our friends from Abbott. Abbott's been a great organization, and we're super excited to have them attend Age+Action this year. The title for our session today is called The Challenges of Falls, Brain Biomarkers, and the Impact of Mild Traumatic Brain Injuries. It's a really important topic, and we're really excited to have Dr. Chris Davlantes today speak on behalf of Abbott and the broader Falls community. Dr. Davlantes is an emergency physician from the United States. He's currently the Senior Director of Global Medical and Scientific Affairs at Abbott Point of Care. He is still practicing emergency medicine on a part-time basis in New York City, and he previously held the position of Assistant Professor in the Department of Emergency Medicine at the University of Kansas Medical Center. Please join me in welcoming Dr. Chris Davlantes to the stage.
Thank you. Thank you very much for the kind introduction, and thank you for having me. I'm very humbled by having the first session in the morning, and I appreciate you joining me. So, brain biomarkers. Why are we here talking about biomarkers? You'd think I'd be up here for Abbott talking about nutrition products or Freestyle Libre to monitor your diabetes. I joined Abbott 2.5 years ago, and one of the reasons I joined them was this new blood test for the brain, which I thought was a game changer. And I really enjoy working in the emergency department. I've been working there for, this is my disclaimer slide, I've been working there for about 27 years, as you can see from my gray hair, and I still enjoy it. I still do it part-time. But I learned about this, and I took on this role in global medical and scientific affairs, and I'm really glad I did. I've been practicing, as I mentioned, I guess my slides aren't animated, but I still practice in New York City. That's a picture of my mom and dad, and he's turning 100 in October. I'm gonna try not to get emotional. This Greek Orthodox Easter was yesterday. I didn't get a chance to get up him because of work. I couldn't get up to visit them, but he still rides his bike to the grocery store, and I hope I get his genes. But that's a picture of my dad. So why am I here talking about concussions? It's kind of a silent epidemic. We see a lot of people worldwide, roughly 69 million patients every year suffer a TBI, traumatic brain injury. The mild traumatic brain injuries we refer to as concussion for the most part. The number is rising in all age groups, but the most common patients that will suffer from concussions are not athletes. It's the patients that are older, over 75. In the US, about 3.5 million people suffer a TBI every year, and it leads to a lot of economic cost and a lot of poor outcomes in many cases. And if you look at this slide, it tells you kind of the causes of TBI, and the most common is an accidental fall. It's not what you'd think, like sports. Everybody thinks of concussions. You think I should be at a sports medicine conference right now, not talking to you about concussions. But the reality is most of the concussions we see are from the general public. It's tripping on the rug. It's losing your balance using your walker to get to the restroom, falling and hitting their head. So almost half of the falls, half of the concussions we see are due to these falls. They're not sports-related concussions. The sports are important. The sports-related concussions we hear about in the press certainly raise a lot of awareness to the general public about the importance of concussion. And there's a great I encourage you to stop by the booth. Concussion Awareness Now is a great program to raise awareness among the general public about why it's important to get seen. Get your melon checked. A lot of people don't understand what concussion is. Half of the cases are underreported or undiagnosed. So it's important to know when to go to the hospital, when to get checked out. That's the reality. Only 3% of sports-related concussions account for the ones we see in our emergency departments. More than 1 out of 4 Americans age 65 or over will fall every year. Falls are the leading cause of fatal and non-fatal injuries among older adults. The cost of treating these injuries caused by falls is projected to increase to over $101 billion with a B, dollars by 2030. And falls result in more than 3 million injuries treated in our emergency rooms annually, including over 800,000 hospitalizations. And it's this older population that succumbs to the serious head injuries that lead to death. So why am I here talking about blood-based biomarkers? Well, first I want to talk about concussions. So over 80% of the head injuries we see are these mild ones. As physicians, we have to categorize head injuries as mild, moderate, or severe, and they're very crudely defined. There are certain criteria we use to determine whether it's mild, moderate, or severe. The majority of the ones we see are mild TBIs or MTBI, and that's basically a concussion. Over 80% of the time, we do a CAT scan. So patients will come and see me, I slipped, I tripped on the sidewalk, I hit my head, I have a headache, and they come there wanting a CAT scan because they think that's going to rule in or rule out a concussion, when in fact that's not the case. 90% of the time when we do a CAT scan in someone who's had a fall, the CAT scan's normal. So why I think blood-based biomarkers is going to really change our practice of medicine and help us to more properly identify and diagnose these falls, it's something very new. We've had a blood test for years. When you come into my emergency department with chest pain, I can measure a protein called troponin, and it tells me whether there's injury to the heart muscle. When you have a kidney problem, we can measure some other blood markers to check your kidney function. When you have liver problems, we can measure your liver enzymes. We've never had a blood test to measure brain injury. And they're studying these biomarkers for the brain for many other things besides head injury. They're studying it for stroke, for Parkinson's, for Alzheimer's, these blood-based biomarkers. So the status quo right now is to do a good exam. We sometimes will do neuroimaging, and there are times when you need a CAT scan. If you're on blood thinners, you're a high-risk population, and many of our older population, patients in our older population tend to be on blood thinners. So they are high risk, and there are CAT scans that need to be done, but there are a lot of unnecessary CAT scans. But we take our exam, we do our imaging in some cases, and then we look for symptoms of concussion: loss of consciousness, headache, dizziness, vomiting, amnesia, blurred vision, and so forth. And as physicians, I won't go into this slide in detail. I know it's very busy for those that are non-clinicians, but we have these things called clinical decision rules. They're basically criteria that tell us, and these are the 3 most commonly used ones, that tell us, I don't know what's happening there, whether or not we need to do a CT scan or not. The problem is with these decision rules is many of the times it relies on somebody witnessing the fall or recognizing that Aunt Mary or Grandma is not acting right. And many times when people come to my emergency room with a fall from a skilled nursing facility, from assisted living, there is no family there to tell me what their baseline is. It wasn't witnessed. They were found, staff may come by and see them on the floor, but we don't really know if they just lost their balance and fell on their butt or if they actually bunked their head. We don't know. So what do? We order a CAT scan, just to be safe, because we're a very litigious society. We don't want to miss a head bleed. So altered level of consciousness, confusion, witnessed injury, those things are not always there. Also, although they are a high risk, as I mentioned, many patients are on blood thinners, and more people have atrial fibrillation and other heart conditions that require blood thinners. There's no doubt those people probably still need to be scanned in most cases, but there are some cases where there was no head injury, or possibly a very minor one, they may not need to have a CAT scan. And it wasn't too long ago that when they had blood thinners on board, we'd scan them, and then we'd watch them for another 6 to 8 hours, and then rescan them, just for the fear of a delayed hemorrhage in the brain. So that was the practice until not too long ago, and studies have shown that delayed bleeding is not as often as we used to think. And then the other criteria are age. So in one criteria, it's over 65, the New Orleans criteria over 60, which I'm getting closer to that. I'm 57, so if I bonk my head and I have a headache and I'm over 60, I'm getting a CAT scan based on these criteria. So they're not perfect. They're great. They try to tell us when to not do a scan, but they're not perfect. We still do a lot of unnecessary CAT scans. So what happens here? This is a very busy slide, but it's telling you pathophysiologically what happens to the brain when there's an injury. There's not always bleeding, but what happens is you have stretch of these things called axons, and you have vascular stretch, so the blood vessels get stretched, and then you have inflammatory changes that happen. So a lot of things happen to your brain when you fall and you hit your head. You may or may not have a skull fracture, and you may or may not have a collection of blood around the brain, but sometimes there's just shearing injury that happens, and all the neurotransmitters, all the chemicals in your brain rely on that network of structural parts of the brain to function. So when you get headache and confusion and memory and depression, which is a common symptom of concussion, it's because the neurotransmitters aren't working properly from the injury that occurred. And you may or may not see those things on a CAT scan. Sometimes you'll see them on an MRI. This shows you all the different origins of blood-based biomarkers. So blood-based biomarkers is nothing new. Again, they've been studied for years for many entities, and they still are. And they come from different origins in the brain. Some come from the neuron, some come from the axon and the glial cells and the astrocytes, which are basically the most abundant part of the brain. So the two biomarkers that Abbott has recently cleared by the FDA are called UCHL1 and GFAP, ubiquitin C-terminal hydrolase L1. Say that 10 times. I don't know why these engineers and scientists come up with these crazy names that are not very easy to roll off the tongue. The other one's called glial fibrillary acidic protein, and I'm going to quiz you later to make sure you remember all this. But the GFAP is the most abundant protein in the brain. It's very specific to the brain. In other words, it shouldn't be in the bloodstream. Just like with a heart attack, you shouldn't have troponin in your blood. When I run a marathon, though, sometimes there is some strain on the heart, and even exertion can cause some of these heart enzymes to go up. But there's very few things that can cause these markers to go up in the brain unless there's actually brain injury. So the presence of these things in the bloodstream is not normal. And that's the premise behind the blood test we're talking about. This is a slide that shows you the kinetics. So where these biomarkers come from, the type of injury that occurs, the type of protein you're talking about, they all go up and down at different times. There are some biomarkers like neurofilament light and tau, which are being extensively studied for chronic traumatic encephalopathy, for longer-term assessment of patients with head injuries. The biomarkers that go up early after fall are the ones I just mentioned, GFAP and UCHL1. So they have different kinetics, and one of the researchers, Dr. Linda Papa down in Florida, has been studying these for over a decade, and she actually measured these blood tests in trauma patients that she was seeing, and she tried to follow how high these went in the bloodstream, and she would check these every 4 hours on patients. And this is kind of the graph that shows how these work. And if you notice, the one in the yellow is the UCHL1. It goes up almost immediately. They think within about 10, 15 minutes of the injury, that marker will be elevated in the blood. So just like heart attacks won't always show up on an EKG, these brain injuries or concussions won't always show up on a CAT scan. In fact, 90% of the time they won't. So when your doctor comes back in your room and tells you your CAT scan is normal, first of all, I walk into the room and I say, good news. And they say, what, I didn't have a concussion? I say, no, I saved a bunch of money on car insurance by switching to Geico. And now I can actually say that I just switched to Geico, for those that remember those commercials. But when they go in and say their CAT scan's normal, they commonly will tell me, oh, does that mean I didn't have a concussion? I can go back to work, I can go back to my normal routine. That's not the case. It just means you didn't have a bleed in your brain. You probably did have a concussion, depending on the mechanism and your symptoms. So these blood tests actually can be much more sensitive than even imaging. There's a big study, I won't go into the details, but there's a large study of over 1,900 patients that tested these biomarkers, again, in trauma patients, a bigger study than the one I showed you earlier, and they showed a very high sensitivity and a very high negative predictive value. So not to bore you with statistics, but what that basically means is very few false negatives. So when you measure these biomarkers and neither of them are elevated, because they have to both be normal for it to be a normal test, then it's very unlikely that you had an injury that would require a CAT scan. And that's how this study got cleared by the FDA, by this very large trial that was done in 22 sites across the US and Europe. So challenging patients are common, and it can be, as I mentioned, an emergency room that's very busy. It may be a patient from a skilled nursing facility. It may be a patient from their home that comes in. And we also tend to get people, I live in Manhattan. For those that are familiar, I just moved. I was living in Meatpacking District. So a lot of people like to imbibe in a little bit of alcohol at some of the pubs there. And so you get even young people that come in that are intoxicated. So that makes it challenging. Do you scan them? Did they fall? Are they having a headache and vomiting because they drank too much? And there are people over 65 that tend to imbibe a little bit too. So when they come in and they're older and they're drinking and they're on blood thinners, it's just a perfect storm. So it raises some confusion. But you have patients with you have elderly patients that come in with challenges like Alzheimer's, dementia, or Parkinson's, or other things where their mental status may not always be normal. So they're confused, but that's their baseline. So how do you know? So it's difficult sometimes to apply those decision rules in those settings. So I can determine as a physician, do I need to do a CAT scan or is there something else going on? Maybe they have a urinary tract infection. Maybe there's some electrolyte problem. So fortunately, we can get a good history most of the time, but not always. And there's sometimes when patients come in, they're very combative. So even if I determine I want to do a CAT scan, I have to actually sedate them to get them to sit still, because some people, let's face it, there are some people that are pleasantly demented, and there are some patients I see that aren't so pleasant. And it's unfortunate, and it's hard to get that person and yank them from their routine, which we know has been shown to cause their dementia to get worse. The last thing I want to do is yank a patient that you're not even sure if they fell or not, but just the medical director at the skilled nursing facility says, send them to the ER and let them check them over. And then they come in an ambulance, we're in a busy ER, it's a change in their environment, and they get even more confused and agitated. Then you have sundowning, and then we're starting to give medications to sedate them, because we have to lay them on a table and stick them in a CAT scanner, or I call it the donut of truth. And it's difficult sometimes. So when you have a blood test, I think to be able to sort things out and give me some objective evidence as a physician that, yes, there may be an injury, or no, they probably didn't have. They're probably confused because that's their baseline, or there's something else going on. I think it's going to be very useful. So most clinicians I've talked to about these biomarkers are very excited, but it's very new. So don't expect to go down the street or to your local hospital and ask the doctor, can you order this brain biomarker test that Abbott has? Because I can tell you right now, most hospitals don't have this yet. It's very new. It just got cleared, and we actually just recently got a clearance from the FDA for a different version of the blood test, which allows us to draw the blood from the vein, whole blood sample from the vein, and just like any other blood test, and put it right into a cartridge, into the machine, and it gives us the numbers. It tells us elevated or not elevated, and also tells us the number, how high the value went. And we have a core lab machine at Abbott also for the hospitals that have the big machines that do all the other chemistries and laboratory tests. They can measure these biomarkers on those big core lab machines as well. But there are situations I can think of as a clinician where this is extremely useful. I've had a case before where I had an elderly person that was a regular frequent flyer. We call them frequent flyers. They come into our ED very regularly. Sometimes they're undomiciled. Sometimes they have mental illness, sometimes they have substance abuse, or they're alcoholics. And we see them 4 or 5 times a week. We know them on a first-name basis. And one of these patients came in by ambulance, were found lying on the sidewalk, minding their own business. A tourist meant well and said, let's call 911, want to make sure they're okay. So they meant well, and they bring them to us, and most of the time they're just intoxicated. We let them sit in the hallway, we check their blood sugar, we check their vital signs, and we let them metabolize to freedom. And there was a case not too long ago where this patient was assumed to be intoxicated and was older in this high-risk population that I just talked about, that are over 65 who have falls. And it was an hour or longer, over an hour later, that she decompensated and started vomiting and aspirated, and I had to end up managing her airway. We sent her to the CAT scanner, and she had a big bleed, a big hemorrhage around the brain. It's called an epidural hematoma. Which can be life-threatening. And so unfortunately, she slipped through the cracks. So I think she was a failure of the system. And whether that person is homeless, or whether that person's an alcoholic or has mental illness that's not being treated because they can't afford their medications, post-pandemic in New York City, I can tell you we're seeing a lot of this. That's still a patient. That's still a human. That's still somebody's mom or grandma or aunt. And I was thinking to myself when I saw that patient, and she ended up not doing so well, but she went up the street to the main hospital, Lenox Hill. So if you watch Netflix, there's a documentary called Lenox Hill. That's where the hospital system where I work. So if you're bored, you can binge watch Lenox Hill sometime when you get home. We had to send her to the neurosurgeon so they could take her to the operating room and take the blood clot around her brain. But my point is, we get complacent sometimes, and so when we see so many of these patients that come in with intoxication or mental illness or You assume it may be their dementia, that's just their baseline, but it's not. How do you know? So having an objective way of assessing patients that can be challenging, where their history is not quite so clear, I think will truly be a game changer. So that's why I wanted to bring this to your awareness, because you're dealing with falls and the population that accounts for half of the falls or concussions that we see. So I think this is going to be something in the future that we'll see more and more, and hopefully it will become the standard of care, just like when you come into the emergency room with chest pain, we check a blood test and an EKG, and we'll hopefully be doing the same in the near future. Because there are a lot of researchers, neurosurgeons, neurologists, emergency physicians, and so forth that are very excited about this new breakthrough. So having objective evidence rather than just subjectively saying, well, she's acting okay, I think she'll be fine, or the converse, which is, let's just CAT scan everybody, right? And that's what a lot of physicians will do. Again, we're in a very litigious society. I speak about concussions all over the world, and in Australia and Canada and other places, they don't have CAT scanners everywhere like we do here. We even have freestanding emergency rooms now in the U.S. where we have CAT scans, MRIs, they can do everything. I work in one, so I'm in the first and only freestanding emergency room in Manhattan. We take ambulances, we're a stroke center, but if somebody is sick and has to be admitted, we have to send them by ambulance up to our main hospital. But think about all of the unnecessary CAT scans that are being done just because we're not sure. A CAT scan of the brain gives you about as much radiation as 100 chest x-rays. So it's not an insignificant amount of radiation, especially in these people that we call frequent flyers that are coming into my emergency room over and over again. So just the ability to reduce the cost, the delay, the patient that comes from the skilled nursing facility that's waiting for hours, sometimes they're in the emergency department for 12 to 24 hours because we're busy and they end up getting a lot of blood tests they may or may not need. And there are delays in not only taking them to CAT scan, because seemingly isolated head injury gets trumped by a stroke or a trauma that comes in, and now my CAT scan is tied up, and now my patient's waiting 2 or 3 hours to get her CAT scan. And then you have to wait for the radiologist to give you the result, which can take an hour or two. I don't know if any of you, show of hands, how many have been to the emergency room for yourself or a family member who has had a head injury? Show of hands. Quite a few of you. And how was your ER? Was it pretty quick like McDonald's drive-through? Probably not. I would say, most people spend 6 to 8 hours in the emergency room waiting, and it's frustrating. But to be able to reduce unnecessary imaging, reduce cost, and reduce radiation, and to help us get patients in and out of the emergency department or urgent cares, I think is going to be phenomenal. And so that's why I think these biomarkers are really going to change the face of how we deal with this situation. I'm not here to sell you anything, I'm not in sales, but I thought, well, how do you test these blood tests or biomarkers? And as I mentioned, there's a handheld device called iStat, which is the division of Abbott I work in, where we can actually check a lot of things. If in marathons, we have iStat in the tents checking electrolytes. We can check kidney function, lactate levels. So it does a lot of things besides traumatic brain injury. But on the right is a machine that's in the core lab that the hospital will have, and it's called Alinity I. So you can measure these 2 biomarkers now on either of these instruments. The exciting thing is the test that was cleared a couple of years ago was on plasma, meaning that if you went to the emergency room, you get the blood drawn, but you had to send it to the laboratory and centrifuge the sample for about 10 minutes and take 2 drops of the plasma and then put it in the cartridge, and you'd get the results in about 15 minutes. But there was a little bit of a delay. So just recently, the FDA cleared a whole blood version of this test, which is truly going to be the game changer. Because now, think about it, you don't need a centrifuge, you don't need a lab, you have a handheld instrument. So in certain skilled nursing facilities, in certain assisted living facilities, and urgent cares, areas outside the hospital, you could theoretically do this test at the bedside, and assuming that they have the ability to do moderate complexity lab testing. So there's some licensure issues, but we're not quite at the point where we could do this on the sidelines at a sporting event, but we're getting there. But you could do this to minimize unnecessary transfers. So Aunt Mary at the assisted living facility doesn't have to get transported by ambulance to the hospital. We could clear her, if that's all we're worried about is a head injury, by doing this blood test at the bedside. Pretty phenomenal. And I think that if you think about the Medicare and Medicaid dollars that are spent from transferring patients back and forth to the ED, and then when I'm done with the patient, I have to send them back to the facility or to their home by ambulance again, in many cases because they're not suitable for a wheelchair van. So the impact this will have on unnecessary transfers, on being able to assess people in the urgent care, because if you go into the doc-in-a-box or the walk-in clinic, you're oftentimes going to meet the same type of kind of risk-averse, litigation-fearing clinicians. They're mid-level providers like nurse practitioners or PAs, and their reflex is, well, let's just send them to the ER just to be sure, and they can do a quick CAT scan. They may or may not need a CAT scan. They may or may not have had a concussion, but they could assess them more objectively in that urgent care if they had a blood test available. So that's what I have. I hope I didn't bore you too much with the science of it, but it is something very new, and I can guarantee you a lot of clinicians still don't know about this. It's a very, very novel concept, but it's there. It's here. Abbott has worked with the DoD for a long time to get these biomarkers cleared, it's very exciting. And I really do think it's going to impact patients in a good way and help us practice medicine much more efficiently. So with that, I'll see if you have any questions. I think I've got about 4 minutes left. If not, I'm happy to take questions. I'll be at the networking lunch and at the reception this evening. So I do appreciate your attention and joining me this morning. I hope you learned something new about the brain and about blood-based biomarkers. And I appreciate your time. Thank you. Do I have any questions from the audience in the back?
Yeah, you mentioned skilled nursing facilities and assisted living, but what about older adults in the home who don't make it to urgent care, don't make it to the hospital? EMS comes into their home. Are you thinking this is a test that can be used actually in the home, and then the test is sent off to a lab? Because that's a huge issue.
Absolutely. So the question was, we talked about urgent cares and freestanding EDs, but for patients that can't make it there, what about the ambulance? And that's a great question.
Yeah.
Until now, that wasn't practical because you can't carry a centrifuge in the back of an ambulance.
Right.
Now with the whole blood being cleared and being commercially available as early as this summer, yes, indeed, you can indeed think of a future where the ambulance would carry this in their ambulance and take it to the patient's home and test them in the living room, just like they do an EKG, and they can do other things. EMS in the US has not been doing point-of-care testing quite as much as in other parts of the world. In Europe and Australia, they are doing point-of-care testing in the ambulance. You have sometimes physicians riding in the ambulance. So we're not quite there yet. It would be even easier if we had a finger stick ability to get the blood with a capillary sample, which they're working on that. But yes, paramedics know how to start IVs, and they, in most cases, know how to draw blood. So yes, that's the future we see, is with the whole blood clearance, bringing this outside of the hospital where you don't have a lab, and you can do it and determine whether they even need to be transported, and they can examine them on the scene. That's a great point.
Yeah, the cost savings and the disruption to an older person's life would be really significant. Thank you.
You're welcome.
Hi, I'm Diana from New Jersey, and I actually work in a hospital, so I'm a little bit different than most people who are here. So I deal with all ages in my injury prevention role, and I'm just wondering what the age group was in that study, and is this applicable to pediatric patients too?
Great question. So the large pivotal trial, and I didn't show you the data from the recent pivotal that led to the clearance of the whole blood cartridge, but the one I showed you was data for the plasma test that's already been cleared. That involved patients 18 or older, so I didn't go over kind of the indications for use of this test at the moment. So in that study, it was 18 to 90. The oldest patient was 90. It did not exclude blood thinners. So those clinical decision rules, we use Canadian CT head rules in the US most of the time. The inclusion criteria for those decision rules and the studies that validated those rules excluded patients on blood thinners, which, as you know, many of our older patients are on blood thinners, they're on Eliquis, they're on Xarelto because they have chronic AFib. So this study did not exclude people on blood thinners, it did not exclude elderly, but it did restrict it to what it was cleared for by the FDA, which is 18 or above. So it's not cleared in pediatrics yet. That's definitely a goal. We would love to be able to do this in pediatric patients because they're just equally as difficult to get to sit still in the CAT scanner. And you don't want to radiate that young developing brain. What needs to be determined is how does those brain biomarkers behave in a developing brain before and after puberty, and how does that compare to an older adult? We know the cutoffs below which the biomarkers can be reliable to reduce the need for imaging, but we don't know for sure if that applies to a 5-year-old or a 12-year-old. So it's only cleared for 18 and above. It's only cleared at the moment for within 12 hours of the injury and the plasma test, but the whole blood clearance recently allows us to test this within 24 hours of the injury. So now you have somebody that fell the day before, maybe they had a couple cocktails, and they wake up the next morning with a headache and vomiting, and they're not sure, is it a hangover? Should I go into the hospital? Within 24 hours of the injury now, you can test this, and it's only to determine the need for CT. So it's not cleared yet as a rule-in concussion test or rule-out concussion test. So I want to make sure that's clear. But that study did include elderly patients. Great question. Thank you. Anyone else? I think we're out of time. Thank you.